Okay, good morning, good afternoon, good evening. It's Dr. Kaz, and this is the second part to chapter 20, the circulatory system. And we were talking about the neuroregulation of blood pressure. So how our nervous system helps to change our blood pressure, either up or down, depending on certain situations. Of course, this brings us back to the concept of our homeostatic mechanism that keeps us all in health and in balance, which deals with a receptor control center and effector. And so our receptors in this scenario are going to be our stretch receptors, and those are the baroreceptors. They're going to monitor the amount of stretch that's going on inside of our blood vessels in this case. So depending on what our blood pressure is going to affect the firing rate of those receptors. So obviously, if there's more stretch, we'll get a higher firing rate. If there's less stretch, we'll get a lower firing rate. The baroreceptors are located in the outer layer, of these blood vessels in the tunica externa there. And we're going to find them primarily, in the aortic arch. We've mentioned this before, and also in the carotid sinuses. And those carotid sinuses are those areas where the common carotid arteries are going to divide or bifurcate into the external internal carotid arteries there. And so when we're talking about the aortic arch baroreceptors, they're going to transmit their sensory input information through the vagus nerve. That's cranial nerve number 10, right? And so this is crucial, especially when we are dealing with a system-wide or systemic blood pressure. Now, the carotid baroreceptors, those are going to transmit their sensory input information to the central nervous system via the glossopharyngeal nerve, cranial nerve number 9. And so these are located in the neck. So pretty much these baroreceptors are going to monitor your blood pressure, pretty much in the head and neck. So obviously, think about the brain. The brain is a very important organ, if not the most important organ in our body. And so these receptors are going to be much more sensitive to any changes in blood pressure than the aortic arch. And you would think it would be the other way around because it's closer to the heart and whatnot, but it's not. And in some cases, folks that get an increase in their blood pressure, sometimes it is encouraged to do what we call a carotid massage, in which you just kind of gently massage, the carotid areas there where you would find your carotid arteries on either side of your neck, just gently. And that will help to stimulate that region to help with any blood pressure issues. Now, I'm not saying you're going to walk, if you have high blood pressure, that you should be walking around all day long massaging your neck. It doesn't work that way, but it does help with changes there. Our cardiovascular center here, you can see, we've seen this picture before in other videos. And so you can see here, as we're looking at our whole reflex or control mechanism here for the cardiovascular region here. We'll have our receptors, and here they're located along the aortic arch here. And then we'll also see them here where we get that bifurcation of the carotid, of the common carotid into our internal and external. We call that the carotid sinus. So we'll see some more baroreceptors located there. In addition to the baroreceptors, we do have chemoreceptors. Obviously the chemoreceptors are going to monitor the content, and we'll talk about that, of your blood, how much carbon dioxide, how much oxygen, what the pH is, So we'll see these receptors located in these various regions, and of course, they'll transmit their information up to the cardiovascular center in the brainstem, the medulla oblongata, We have those two regions there, the cardio-acceleratory center and the cardio-inhibitory center. And then depending on what is occurring with your blood pressure, the motor output will then travel down, either through sympathetic neurons, that are going to travel through the sympathetic chain, and out to various blood vessels or back to the heart. And then we'll also have our parasympathetic neurons, which will travel through the vagus nerve, down to the heart here. Because remember, keep in mind, blood pressure, blood vessel diameter is only governed by the sympathetic nervous system. We have two receptor types, though, when we're dealing with our blood vessels. We have the alpha-1 receptors that are located in the vessel wall, right? And they're going to, when stimulated, they'll cause vasoconstriction. And then we have our beta-2 receptors also in the blood vessel wall, and they'll, when stimulated, will cause vasodilation. All right, so let's talk about, all right, reflexes. Right? Understanding this whole concept, we do deal with, the receptor, control center, effector mechanism there for homeostasis, but don't forget, these are reflexes, and so therefore you do need a stimulus here. So when we're talking about our baroreceptor reflexes, we're going to be monitoring the stretch on the blood vessel wall. So the two types of stimuli that can occur are either going to be an increase in stretch or a decrease in stretch. So let's talk about, right, what happens when we get, all right, blood pressure decreasing. Right, so when our blood pressure decreases, the stretch on the wall there is going to also decrease. Therefore, the firing rate will also decrease. And so as a result of that, all right, we are going to then stimulate the cardioacceleratory center, right? And therefore, cardioacceleratory is going to then send out its motor output via the sympathetic pathways. This is one of those situations when we're dealing with the autonomic nervous system in which, all right, the sympathetic nervous system is going to increase heart rate, right? It will help to increase blood pressure. And then whereas the parasympathetic is going to be antagonistic of that, and that's going to decrease the heart rate and the cardiac output. So when we stimulate the sympathetic nervous system, we're going to increase our cardiac output. Don't forget, cardiac output is equal to heart rate and stroke volume. Right, so what we're going to do to increase, we've talked about this in previous chapters, right? If you increase heart rate, you increase cardiac output. If you increase stroke volume, you increase cardiac output. So either one of those or both of them are going to increase the cardiac output. Now, meanwhile, as we're increasing or stimulating the cardioacceleratory center, we want to inhibit the cardioinhibitory center. Right, so we really want to minimize any parasympathetic activity that's going to occur in the heart. Because remember, we're trying to increase that cardiac output. We don't want to work against ourselves. Right, so because we've stimulated the sympathetic nervous system there, right, we are then going to stimulate our vasomotor center. And in doing so, this is going to cause vasoconstriction, right? Those alpha-1 receptors will be stimulated, will cause vasoconstriction, right? And that vasoconstriction will increase the systemic resistance, right, in our circulatory system. And that's one of the ways that we're able to increase blood pressure, right? Our blood pressure is equal to, one of the equations that we use, blood pressure is equal to heart rate times what we call total peripheral resistance. So again, if we're increasing our heart rate, right, through the cardioacceleratory center, getting more, the heart starts to beat faster, we can also increase our blood pressure by upping or increasing the resistance in our circulatory system. We do that through the vasomotor center. In doing this, that increase in both the cardiac output and in our that increased resistance in our vascular system, all of that is going to increase or raise our blood pressure. And that's our reflex to a decreased blood pressure. So what happens now if we increase our blood pressure? Okay, so we're going to pretty much, I don't want to say necessarily do the opposite, but we're going to do some things that are going to try to decrease our blood pressure. One of which we'll see, because the baroreceptors now are going to be stimulated more because there's an increased stretch in the vessel walls. So the firing rate for those baroreceptors increase. So this, we're going to now see where we need to shut down our cardioacceleratory center. So we'll send less sensory information, all right, to the cardioacceleratory center. While that's going on, we are now going to stimulate the cardioinhibitory center. And that's going to work on our parasympathetic nervous system. And so the parasympathetic neurons are going to send that motor output information to the SA and the AV nodes in the heart. And that is going to then decrease, all right, the heart rate, thereby decreasing your cardiac output. All right, now, again, remember, sympathetic nervous system is the only division of the autonomic nervous system that can affect the diameter of your blood vessels. So again, what we're going to do here is, all right, we're going to stimulate the vasomotor center less. We're going to send less signals, right, along those sympathetic neurons, right? And by doing so, that will cause those beta-2 receptors then to cause the smooth muscle to vasodilate, right? It relaxes because we're not stimulating, all right, that smooth muscle. And so we will see, all right, a decrease in the resistance in our circulatory system. So we are able to effectuate decreased blood pressure, right, because we've decreased the cardiac output, because we've decreased the heart rate, and the smooth muscle in our blood vessels there, all right, is relaxing and causing vasodilation. So therefore, we've also decreased the resistance, right, in our circulatory system. So all of that will help to lower the blood pressure there. Now, this whole system, the autonomic reflex system, is great if we want to make quick changes, right? But this can't go on forever. Right? So we're going to now talk about how we can affect, all right, long-term blood pressure regulation. Right? That's where we're going to utilize our endocrine system. As you recall, and nervous system can get change to happen quick, right? Endocrine system, it takes a little bit longer to effectuate changes, right? But those changes can last longer. So let's go ahead and talk about our long-term. So if we're going to talk about, all right, the endocrine system, we should talk about our chemoreceptors. The chemoreceptors, again, they're another grouping of receptors. We've learned about these before. They're going to monitor, all right, the chemical content of wherever they're located. So in this case, since we're talking about the circulatory system, it's going to monitor the chemical content, otherwise known as our blood chemistry. All right, it's going to monitor that and see, all right, what's in there. Do you have enough of what's in there? Or do you have too little of what's in there? And it's going to undergo our negative feedback system, all right, our negative feedback reflexes to effectuate that change, to bring us back to homeostasis, to bring us back to normal. And so this is going to involve both of our respiratory and our cardiovascular systems here. So again, our chemoreceptors are located, all right, in the same areas, all right, that our baroreceptors were located, in the aortic arch and in the carotid bodies there, right? And when we're dealing with the aortic arch chemoreceptors, right, the aortic bodies, they're going to, again, utilize the vagus nerve to send sensory input information to your autonomic nervous system. And the carotid bodies, same thing, okay? They're going to send that sensory input information, right, to the central nervous system via the glossopharyngeal nerve, cranial nerve 9. So what are the chemoreceptors looking at, right? Well, they're going to be monitoring primarily carbon dioxide, right, pH values, right, and oxygen. So the big push for effectuating change, all right, to our circulatory system, our blood chemistry, is really going to be majorly dependent upon carbon dioxide. Also hydrogen ion concentration. Oxygen, not as much, it still does, all right, but carbon dioxide and our hydrogen ion concentration are going to play a big role in blood chemistry, more so than oxygen saturation in regards to the content of how much oxygen is in the blood versus how little, okay? But it still does play a role. Don't get me wrong on that. So high carbon dioxide, low pH, and very, very low oxygen are going to stimulate our chemoreceptors. We'll talk about how that affects the blood pressure and whatnot, and then also our vasomotor center there. Right? So what we'll see, for example, if we have an increase in blood pressure, right, we want to get the blood to the lungs so you can breathe off as much carbon dioxide as possible. And when you decrease carbon dioxide levels, then you're going to decrease the hydrogen ion concentration in the blood as a result of that, and therefore that will cause an increase in pH values. Low pH, you're more acidic. High pH, you're more basic or alkaline. Remember, that value that we want to get our blood in is that 7.35 to 7.45. Basically, 7.4 is the value that we're looking for. All right, some other neuroregulation of our blood pressure. All right, we can't forget about the hypothalamus. Hypothalamus plays a role, all right, in increasing both cardiac output, again, and resistance. So therefore, it plays a role in that blood pressure regulation. And so we'll see, because the hypothalamus is involved in almost everything, it pretty much governs our autonomic nervous system, fight or flight, all right, that sympathetic response, right, can cause an increase in blood pressure. Also, we've seen, all right, body temperature changes, especially if we increase our body temperature, we'll also see how it can affect, because our hypothalamus plays a role in temperature regulation, right? It can also affect cardiac output and resistance. And then, of course, we can't forget about our limbic system, right? When you get emotional, fear is a great motivator to keep you alive, all right? And so if you are in a situation in which you are terrified for whatever reason, you're running from something, right, the limbic system will also play a role in blood pressure regulation there. All right, so let's climb into the endocrine system here and talk about how we are able to regulate our blood pressure through hormones. So let's talk about the Renin-Angiotensin system. We talked about this, right, way back in the beginning of this course when we were learning about the endocrine system. Right, the liver, wonderful internal organ, the largest of all the internal organs, right? It is going to make angiotensinogen, right? Now, tensinogen tells us that it's inactive, right? It is an inactive protein, right, that the liver makes and releases into the blood. And it does it quite frequently and quite often. So it's in circulation, but it's inactive. It's not doing anything, right? It's not doing anything until it comes in contact, right, with renin. Renin is released by the kidney. And it's released by the kidney into our bloodstream when our blood pressure becomes quite low. Or if the sympathetic nervous system stimulates the kidney to release renin. So there's two possibilities for renin release: either low blood pressure or the sympathetic nervous system stimulates the kidney to release renin. So renin comes floating along, interacts with angiotensinogen, and it is going to convert that angiotensinogen into angiotensin I. Angiotensin I. Now, angiotensin I will circulate throughout the circulatory system in the blood, and it'll eventually make its way to the lung. And in the lung, all right, we have a very special enzyme. It's called angiotensin converting enzyme, also known as ACE. We have a group of drugs called ACE inhibitors, which help to regulate blood pressure. Okay, if you have high blood pressure, this helps to decrease it. Well, this enzyme, right, is produced in the lungs, and it's going to convert angiotensin I into angiotensin II. And here we're going to talk about the effects of angiotensin II, but angiotensin II is then going to help to increase our blood pressure. We'll talk about this here in a moment. Right? So how does it do it? How does angiotensin II increase the blood pressure? It helps to cause vasoconstriction, right? So keep in mind, where are you? right? I'm going to write this out here for us so we have so it's just helpful. All right, so BP, right, is equal to heart rate times TPR. Okay, that's our total peripheral resistance there. Okay, so as you can see, if we increase, all right, if we increase our resistance in our circulatory system by causing vasoconstriction, we increase TPR, then we'll increase blood pressure. Right? What else does it do? Well, it makes you thirsty. Okay, that's important because when you are thirsty, you are going to hopefully, imbibe more fluid. And when you imbibe more fluid, all right, eventually fluids that you ingest are going to find their way to the blood. Okay, and so that is going to increase your blood volume. Blood volume is very helpful, all right, in helping to increase your blood pressure. We'll talk about that in later chapters, all right, when we get to our fluid content and our metabolism and whatnot, but we will talk about that. All right, but for right now, just know when you get thirsty, you're going to drink more. You drink more, you increase your blood volume. And that blood volume will then cause more stretch, right, on the vessel walls there. Also, angiotensin II is going to go to the kidneys, and it's going to, this is important, decrease urine formation. If you're decreasing the urine formation, you're going to be peeing less. And if you're peeing less, that means you're going to retain more fluid. So less fluid is lost. This also helps to maintain your blood volume. And then finally, angiotensin II is going to stimulate the release of aldosterone from the adrenal gland and antidiuretic hormone from the posterior pituitary. And both of those, and we'll talk about this in a moment, are going to help to increase your blood pressure also. So here's a nice picture of the renin-angiotensinogen system. You can see the liver is going to be releasing the angiotensinogen, and then that angiotensinogen, okay, is an inactive hormone that flows throughout the circulatory system. The kidney releases renin. All right, renin will then cause that angiotensinogen, all right, to convert into angiotensin I. Again, still not doing anything until it gets to the lungs, right, or interacts, right, with ACE, angiotensin converting enzyme, and that angiotensin converting enzyme then will cause angiotensin I, all right, to convert into angiotensin II, thereby becoming the active hormone. And then angiotensin II, right, causes vasoconstriction, will cause you to get thirsty and drink more fluid, all right, decreasing urine formation and also stimulating the release of aldosterone, all right, and ADH. Okay, so aldosterone, quick review here. It does help to maintain that blood volume and our blood pressure. It is released from the outer layer of the adrenal cortex, right? The zona glomerulosa, okay? And so there's going to be, and we'll talk about it more when we get into the kidneys there, right? When we talk about how they regulate fluid content. But angiotensin II is one of the stimuli, all right, that will trigger the release of aldosterone. And aldosterone, all right, is going to increase the absorption of sodium from the kidneys. And by doing so, keep in mind, and I've mentioned this before, and if I haven't, I apologize. I want you to think of water as a follower, okay? It's just a follower. It gets into peer pressure very, very easily. And so water likes to follow things. It follows glucose, right? That's why people with diabetes are always having to pee a lot, okay? And water likes to follow not only glucose, but it follows sodium. So if the kidneys are retaining sodium, if they're absorbing sodium and not excreting it into the urine, right, water is going to follow that sodium, and it too will not be excreted in the urine. So because of this, we see a decrease in our urine output because we're not getting rid of sodium, therefore we're not getting rid of water. right? Antidiuretic hormone, ADH, also helps to maintain, and in cases we can see it also elevate our blood pressure. Now, ADH is not made in the pituitary gland. If you notice here on the screen, it says released from the posterior pituitary, but not synthesized or produced by the posterior pituitary. The hypothalamus makes antidiuretic hormone, and then it stores it in the posterior pituitary. Then when stimulated, the posterior pituitary will release antidiuretic hormone, right? And so, all right, antidiuretic hormone, right, when it is released, right, it will also cause, right, an increase in water reabsorption in the kidneys. Therefore, if you're keeping water, you're not peeing it out, so you'll have less in your urine. Where does this water go? It goes back into the circulatory system, helps to maintain that blood volume there. And this makes you thirsty. So we saw how angiotensin II makes you thirsty. Well, guess what? ADH also makes you thirsty. So of course, when you're thirsty, you drink more. And when you drink more, you're adding more to your blood volume, right? And in large amounts, we will cause vasoconstriction. When we cause vasoconstriction, I hope you know it by now, right? We are going to increase our total peripheral resistance. And therefore, that's going to cause an increase in our blood pressure. That is why sometimes you may see that ADH is referred to as vasopressin. Hardly ever called that anymore, but all right, it's just a lot more people like to refer to antidiuretic hormone as ADH instead of vasopressin. All right, so we learned about what can increase our blood pressure or maintain our blood volume. What about the opposite? Right, well, we have a hormone called atrial natriuretic peptide, ANP. This is going to decrease our blood pressure. How does it do so? Well, we know that ANP is released when we have an increase in the blood volume. We just talked about what increases our blood volume, right? So we see an increase in blood volume, that is going to cause an increase in the stretch in the walls of the atria. And so when there's an increase in stretch in the walls of the atria, right, the baroreceptors there, monitor that. And so this causes the release of ANP from the atria. And what ANP causes is vasodilation. Vasodilation decreases, all right, that peripheral resistance, all right, and our equation there, blood pressure equals heart rate times total peripheral resistance. So if we decrease the total peripheral resistance, we'll decrease our blood pressure. And ANP is then going to affect urine output. And what it does is it helps to decrease our blood volume by increasing the urine output by just getting rid of water. Pee that water out. And if you pee the water out, you'll decrease your blood volume. Therefore, you'll decrease your blood pressure. So you can see there's lots of different variables that influence our blood pressure. Okay, some will be, just the stretch on vessel walls. All right, others could be sympathetic nervous system activity. So there's a lot that go on. So you can kind of see all these variables, and this is constantly going on. And this is one of the many tools, all right, that your body uses, all right, to keep your blood pressure in that normal range. And we'll talk about it. I know if you've taken my classes, I have mentioned the normal range for blood pressure. All right, the high end of that normal range is 140/90, and the low end is 90/60. So usually we try to keep people about 120/80, and I'll explain those numbers here in a moment here. So how do we measure as a clinician, or as a healthcare provider, as an EMT, all right, paramedic, whatnot, the blood pressure? Well, we have this fancy tool called the sphygmomanometer, and what this tool does is we put this cuff around your arm and we pump it up, and it will occlude blood flow temporarily. And then we place, all right, our stethoscope over the brachial artery in your arm, all right, usually right there, all right, near the medial epicondyle of the humerus. Okay, and so we inflate the cuff and we compress that artery until, all right, there is no blood or we can't hear any blood moving through there. And then we start to slowly release the air, and that decreases the pressure inside the cuff. So when we hear a sound, that first sound, that is going to be, all right, your systolic pressure. That's the top number. So you're looking at 120 over 80, right? The larger number, that's that top number, that's the systolic pressure. And so the systolic pressure, we know that systole is when the heart's contracting, and the bottom number is the diastolic pressure, and we know that diastole is when the heart is relaxing. So when we hear that first noise, okay, that's your systolic pressure, right? Then that bottom number, that's the diastolic pressure, right? That's when our heart relaxes. And really what we're doing is we're listening, all right, to the stethoscope when we can no longer hear that beating, all right, that thumping in the stethoscope. And that'll be the diastolic. So the first sound that you hear will be the systolic. And then once you stop hearing it, that's the diastolic. So, all right, you may have heard of high blood pressure, but the clinical term for that is hypertension. And this is for folks that have, all right, chronically elevated blood pressure, right? All of us get hypertensive when we're exercising, all right? So, but when it stays elevated, that's a chronic issue. So anything that is over 140 systolic, all right, and over 90 for diastolic, that is hypertensive. So we have to think of some issues with that, okay? If your blood pressure is elevated constantly, right, this can cause problems for your blood vessels, right? And it can cause damage to the blood vessels. And when you damage the blood vessels, then you're going to open the door to certain conditions, all right, like atherosclerosis. And atherosclerosis is going to be a condition in which you get plaquing, all right, inside of the blood vessels. What is plaquing? Well, we've learned what happens when a blood vessel gets damaged, okay? And what we'll see is once that blood vessel is damaged, and if you have high lipid content, all right, lipidemia, that those lipids will start to accumulate in that area where there is a damaged blood vessel, and you'll get this fatty plaque buildup there. And what does that cause? That causes increased resistance, all right, to blood flow. Increased resistance to blood flow can elevate your blood pressure, all right? So this other condition that we can also have is called arterial sclerosis. And that's when we get a thickening to an arteriole. And that can also be because that arteriole becomes less elastic, right? And so all of these issues can lead up to heart failure, because remember, the heart is the pump that is driving all of this, moving blood through your circulatory system. So if you're constantly making it harder for the heart to push and move the blood through your circulatory system, you are increasing the likelihood of heart failure. And that, my friends, is not good. And let's finish up here and talk about hypotension. All right, hypertension is chronically elevated, high blood pressure. Well, what about chronically low? What about chronic low blood pressure? All right, so what are those values looking like? Anything that is below, all right, 90 millimeters of mercury for the systolic pressure, and anything that is below 60 millimeters of mercury for the diastolic pressure. All right, so what happens if you are hypotensive? Well, right, if we're not getting enough blood circulating throughout, right, certain tissues, certain organs aren't getting the much required and needed amount of blood, nutrients and whatnot. And so you will start to see and feel, all right, certain conditions and symptoms like fatigue, feeling tired, all right, dizziness, fainting. All right, a lot of times when people pass out, all right, is because they're not getting enough blood flow to the brain. And that brings me here to orthostatic hypertension. And some of you may have experienced this before, where you stood up too fast when you were sitting down and you get lightheaded, in some cases dizzy, and you might even pass out. And that's because we haven't given our blood pressure system, all right, enough time to regulate that blood flow. You may have had too much blood pooling in the venous, in the veins in your legs, in other areas, and it wasn't able to get to the areas of the brain. So you may have felt a little bit lightheaded or dizzy. So a good way to prevent orthostatic hypotension is not to stand up too quickly. All right, my friends, I hope you enjoyed that video. That is the end of the circulatory system. Everybody have a great day and enjoy.